Good morning, everybody. It's 10 o'clock. I am Dr. Raymond Oliva. I'm a clinical associate professor of the Philippine General Hospital and a fellow of the Philippine College of Physicians. We welcome you to this third installment of the partnership of the Philippine College of Physicians and the Department of Health on a series of webinars on COVID-19. So today uh, we are very fortunate to have two distinguished speakers to talk about COVID-19 management. One is an infectious disease specialist and one is a pulmonologist. So the title of the webinar is COVID-19 Management, Lessons Learned and Challenges Ahead. And the general objective is really to discuss the present management and future clinical trials in the treatment of COVID-19. And the specific objectives will be to present the latest COVID-19 classifications, discuss latest guidelines in the management of COVID-19, discuss some of the clinical trials in the future for COVID-19, and also the ongoing clinical trials here in the Philippines, and discuss the issues and challenges in COVID-19 management. So for the first speaker, she is the Acting Associate Dean for Research and the head of the Research and Implementation Development Office of the UP College of Medicine. She is the director of the Institute of the Clinical Epidemiology National Institutes of Health and a Professor 10 of the Department of Clinical Epidemiology of the UP College of Medicine and is presently the president of the Philippine Society of Microbiology and Infectious Diseases. So friends, let's all welcome Dr. Marisa Alejandria.
Good morning, everyone. Thank you, Dr. Raymond, for the kind introduction. And thank you to all our listeners who have logged in this morning to listen to this webinar. So our objective for today is to look at the management of COVID-19. And the task given to us is to discuss lessons learned, challenges ahead. And I think since we are just probably just in the middle of the epidemic, there are still lessons to be learned, lessons we are learning, and there are challenges ahead that we have to really look forward to. So thank you to the Philippine College of Physicians and the Department of Health for organizing this webinar. So let's start off with a review first on the coronaviruses. Okay, so this is the virus that is now the in the center stage that is causing this big pandemic. So as we all know, the coronavirus is a large group of envelope positive strand RNA viruses infecting mammals and birds. And there are 4 genera under this coronavirus: alpha, beta, delta, and gamma. And it's the alpha and beta coronaviruses that are known to infect humans. And these human coronaviruses are primarily respiratory pathogens. And there are 4 human coronaviruses that are endemic globally, accounting for 10 to 30% of URTIs in adults. So these are the ones that cause your common cold. And as we all know, in early January, that is when we identified a new member of the coronavirus family that has infected humans. So that's SARS-CoV-2, formerly known as 2019 nCoV. So again, it's a single-stranded envelope RNA virus belonging to the beta coronavirus group 2B. And genetic sequences have shown that it's 80% identical to the SARS coronavirus and 50% identical to the MERS-CoV, or your Middle East Respiratory Syndrome coronavirus. And this SARS-CoV-2 is the 7th member of the coronavirus family that has infected humans. The first 4, as I mentioned, is the ones that is endemic across the world, causing common colds. And then the 3 that have emerged, in the past, in this 20th century, we have SARS, which emerged in 2002, and MERS-CoV in 2012, and now SARS-CoV-2. So these are all beta coronaviruses that cause adult respiratory distress syndrome. And it has also been shown by genetic analysis that these 3 respiratory viruses that have emerged originated from bats. And mammals is the most likely link to humans. As you all know, SARS was transmitted to humans by civet cats, and MERS-CoV by camel. And for this SARS-CoV-2, it's probably also from mammals. We haven't really identified which species is responsible for the jump from animals to humans. So SARS-CoV-2 targets the cells through the viral structural spike protein that binds to the angiotensin converting enzyme, or ACE2 receptor. So you're all familiar with this structure already, this electron microscope picture of the virus and the spike proteins that gives it the corona picture, or that resembles the corona. And these spike proteins are the ones that are responsible for entry of the virus into the cell. So let's walk you first through the viral life cycle of SARS-CoV-2 and how it causes disease. As you all know, the viral particle has to enter the cell and multiply for it to be able to cause disease. So this figure from the JAMA article on review of the pharmacology of drugs is what I'm using to illustrate the life cycle. So the entry of the viral particle is facilitated by 2 receptors, the ACE2 receptor and the type 2 transmembrane serine protease. And once inside the cell, the respiratory epithelium cells, membrane fusion and endocytosis occurs, and then there's uncoating, release of the RNA, and then synthesis of non-structural proteins. And this leads to synthesis of the RNA through the RNA-dependent RNA polymerase. Then structural proteins are then synthesized, leading to the completion and assembly of the viral particles, which are then released into the bloodstream. And that is when now the host responses come into play, determining whether you will develop mild, moderate, severe, or critical disease. So depending on how your immune system will respond, whether you will go into an overdrive, and which leads to this cytokine storm. So we'll go back to this diagram later when we talk about the different investigational drugs for COVID-19 and the drug targets. So for now, let's review first the case classification for surveillance that we have been using. So at the start of the pandemic, early Feb, so you all know that we've been using PUM, PUI, and COVID-19 positive or confirmed, which is based on the results of the test. And as the pandemic progressed, and as we've seen that it is still continuing, a new classification was developed in March by WHO, and we are now using this classification for surveillance purposes. So PUM now is your asymptomatic contact, and then your suspect case are those that are still for testing, probable are those with inconclusive results, and confirmed if you have positive SARS-CoV-2 PCR assay. Okay, so let's review, no? So the definition of a suspect case. From a surveillance perspective and also from a clinical perspective, since we are still in the middle of the pandemic, and we do not foresee that it will go away soon. So it will really be part of our differential diagnosis in the clinics. So we still have to continue to have heightened surveillance, heightened index of suspicion for patients who present with severe acute respiratory infection where no other etiology fully explains the clinical presentation. And then we also have to still be on the lookout for influenza-like illness cases with no other etiology that fully explains the clinical presentation. And we have to be very vigilant and detailed with regards to our epidemiologic history, asking the patients on history of travel or residence in an area where there is local transmission of COVID-19 disease during the past 2 weeks prior to symptom onset, or whether the patient had history of contact to a confirmed or probable case of COVID-19 disease during the 14 days prior to the onset of symptoms. So we need to ask during our history whether there are household members who presented with fever, cough, shortness of breath, or had unexplained death due to respiratory symptom. So we have to also be have a high index of suspicion for individuals with fever, cough, shortness of breath, or other respiratory signs, among the elderly, those with comorbid, those with high-risk pregnancy, and among our healthcare workers. So we still cannot let our guard down. So even if we relax quarantine measures, the surveillance system, contact tracing, our index of suspicion should still remain high because the cases are still there, and we might expect a surge or a second wave if we let our guards down. Now, how do we define a contact? No? Contact is a person who experienced any of the following exposure 2 days before or 14 days after the onset of symptoms of a probable or confirmed case. Why 2 days before? Because studies on transmission dynamics have shown that at least 2 days before the symptoms, the patient may actually be shedding already the virus. So this is what we call the pre-symptomatic phase, and you can possibly transmit already the disease. So this are the forms of contact that are considered significant: face-to-face contact with a probable or confirmed case within 1 meter and for more than 15 minutes, direct physical contact with a probable or confirmed case, direct care for a patient with probable or confirmed COVID-19 disease without using the proper PPE, or other situations as indicated by local risk assessment. So for confirmed asymptomatic cases, the period of contact is measured as 2 days before through 14 days after the date on which the sample was taken, which led to confirmation. While the probable category are for the suspect cases for whom the testing is either inconclusive or indeterminate, warranting a repeat of the test, or if it remains inconclusive and indeterminate, then this is reported as probable. And reasons for inconclusive or indeterminate results may be because the specimen is not adequate, or the timing of collection, or the viral load is not enough to for the test to be to detect the enough virus. Okay. So that's for probable. So also probable can also be used for cases for whom testing could not be performed for accessibility reasons, or tests that are not conducted in recognized accredited laboratories. And confirmed case, as you all know, is any individual, irrespective of clinical signs and symptom, with a laboratory confirmed COVID-19 test conducted at accredited labs. So that's for the uh, case classification for surveillance. Now, in the clinics, in addition to reporting them as suspect, probable, or confirmed, we also classify them as mild, moderate, severe, or critical, depending on their clinical presentation. So the mild form, which as you all know, 80% of cases will actually have the mild form of illness, especially among the young and without comorbid illnesses. So these are the ones who present with non-specific symptoms of fever, fatigue, cough, anorexia, malaise, myalgia, sore throat, or new loss of sense of smell or taste, or headache. And diarrhea, nausea, and vomiting are also non-specific symptoms that we can see in COVID-19. So you can note here, the signs and symptoms are actually very non-specific. So the epidemiologic link is always very important in our history taking. So that's the mild form. So mild form usually we just present as the upper respiratory tract infection or a mild pneumonia with no respiratory distress. And while moderate, the moderate classification will include the elderly with stable or unstable comorbid conditions presenting with pneumonia without respiratory distress. And severe are those with respiratory distress with pneumonia and respiratory distress, or your CAP high risk. And some will, if they present with severe sepsis, or then that's also classified as the severe case of COVID-19. So presenting with tachypnea, severe respiratory distress, and oxygen saturation below 93%. And the critical stage is when adults develop now the respiratory distress syndrome coupled with some with or without septic shock. And these are the different stages of ARDS, which will be elaborated later by our pulmonologist, Dr. Lenny Fernandez. That's the clinical classification. And I just flashed here also the PhilHealth classification that you have. This is the final diagnosis that you have to put in the charts for our patients to be reimbursed. So under clinical, so you have your COVID probable, mild, moderate, severe, and critical. So that has to be reflected also in the PhilHealth in your charts, in our charts, and then COVID confirmed, mild, moderate, severe, and critical. So our patients will be covered whether they're COVID probable or COVID confirmed. Under probable, these are the patients who test negative on PCR, but there are other findings that support the diagnosis of COVID, such as the presence of leukopenia or lymphopenia on CBC, presence of typical infiltrates on chest X-ray, bilateral infiltrates, or ground glass opacities on CT scan, and elevated biomarkers. Okay. So here, so just to summarize, just to remind everyone that RT-PCR still remains the gold standard for diagnosis, and this is what is used for surveillance purposes also to count the number of cases to monitor the epidemic, whether we are already controlling the epidemic or not. And as I mentioned, these are your ancillary diagnostic tests. As a clinician, we have this supportive diagnostic test to guide us on whether we will proceed to manage the patient as COVID or non-COVID, depending on the clinical presentation, again, the history, and this supportive laboratory examinations. As you know, RT-PCR is not a perfect test, so only 70%, 80% sensitivity, and there are false negatives, which can be due to the timing of collection, the severity of the illness. And then you have these biomarkers to monitor which of your patients will go into cytokine storm. And then again, your liver function test, renal function test as part of good practice to monitor response to treatment, to monitor for adverse reactions, and then do ancillary cultures also to check if based on history or your other findings on CBC X-ray to check if there is secondary bacterial infection or there are other concomitant respiratory viruses. Especially as we move into the flu season, then we have to consider other differential diagnosis also. And patients with comorbid conditions have to also be, you have to also monitor the comorbid condition on the COVID diagnosis. So what are our treatment options? Okay. So regardless of the classification, whether it's mild, moderate, severe, or critical, the cornerstone of treatment is still best supportive care. There are no approved effective treatments at this time. Supportive care, answer, hydration, antibiotic, or bacteria. We have rational then we add patient that's concomitant. To progress to severe respiratory management is very important, as well as intensive care support, as will be discussed later by our second speaker. So these are the investigational treatments for COVID-19 that all of you have read and that we've been offering to our patients on as off-label use or compassionate use, and now if as part of a clinical trial. So the most studied and the most used is your anti-malarial, the chloroquine or hydroxychloroquine, and we have your antivirals and the immunomodulators. So let's go through each of these investigational treatments. What is the current evidence for them at this time, and what's the rationale for their use? Okay. So now let's go back to this diagram. So this diagram shows the potential drug targets that that is the subject of all the clinical trials now, and serves as the basis for the rationale for the clinical trials on these different investigational drugs. Okay, so we have here camostat mesylate, which is used for pancreatitis. It inhibits the TMPRSS2 receptor, prevents viral entry. Umifenovir or Arbidol also targets ACE2 interaction. It inhibits membrane fusion of the viral envelope. And as I mentioned, the most studied is chloroquine, which inhibits viral entry and endocytosis by multiple mechanisms. So let's go in detail and look at chloroquine and hydroxychloroquine. So we all know that it's an anti-malarial drug, and it's also used for autoimmune disease such as SLE and rheumatoid arthritis. Pharmacologically, its CQ has less toxicity and fewer drug interactions than chloroquine. So the proposed mechanism of action and the rationale for using this anti-malarial drug for a viral infection is this. So as I've showed earlier, chloroquine and hydroxychloroquine increase endosomal pH, inhibiting fusion of SARS-CoV-2 and the host cell membrane. Chloroquine in particular inhibits glycosylation of the cellular ACE2 receptor, which may interfere with the binding of the SARS-CoV to the cell receptor. And in vitro, both drugs block the transport of SARS-CoV-2 from early endosomes to endolysosomes, which are required for release of the viral genome. And a systematic review of in vitro studies have shown that chloroquine has activity against SARS-CoV. Aside from its antiviral activity, chloroquine and hydroxychloroquine also have immunomodulatory effects. So it inhibits cytokine production, autophagy, and lysosomal activity in host cells, which is probably why it's the most studied, it's readily available, and it has both antiviral and immunomodulatory effects. So what does the clinical data show us? So this rapid review done by Drs. Leah Palileo and Eleanor Uy shows that there are two published RCTs done in China. These are small RCTs which showed improvement in chest CT scan findings compared to standard of care. However, this did not translate into disease improvement or reduction of disease progression. It did not result in reduction in mortality or improvement in symptoms. And then just recently, another RCT was published last Friday. It's a preprint publication by Tang et al., published in Med RxIV article. This RCT, however, just looked at the incidence of viral negative seroconversion by day 7 and by day 28, and it showed that there was no significant reduction in or improvement in the time for conversion of SARS-CoV-2 to negative. So viral negative conversion was not shown to be hastened with the use of hydroxychloroquine. So to date, the use of chloroquine and hydroxychloroquine has mostly been from mild cases and moderate disease. The data on severe and critical COVID-19 is limited. And there are now 19 ongoing RCTs on hydroxychloroquine or chloroquine as treatment for COVID-19. So 13 on HCQ or CQ alone, and 6 in combination with other antivirals or with an antibiotic such as azithromycin. And we have an upcoming large RCT using an adaptive design that will look at the efficacy and safety of hydroxychloroquine plus azithromycin compared to standard of care. So this is the ACT or anti-coronavirus therapy to prevent progression of COVID. This is an initiative by McMaster Canada, the Population Health Research Institute, and it will be a multi-country trial. Philippines will participate in this large trial to be led by Dr. Leah Palileo and with submitted for funding to PCHRD. So we are looking forward to this large trial, which will answer the question on whether combination of hydroxychloroquine plus azithromycin is effective in the treatment of COVID-19. Then also just recently, the May 8 issue of the New England Journal came out with this large observational study of hydroxychloroquine on hospitalized patients in New York Presbyterian Hospital, Quaternary Acute Care Hospital. So they studied the association of giving hydroxychloroquine to the outcome intubation or death in this big observational study. They look at the effect of hydroxychloroquine given at 600 milligrams BID on day 1 and 400 milligrams OD for 5 days on whether it's associated with a reduction of intubation or reduction in mortality. So this large cohort reviewed the chart of 1,446 adult patients admitted during the study period. But they excluded patients who died or intubated in within 24 hours. So this study cohort eventually analyzed 1,376 patients, and this study showed that controlling for confounders such as sex, chronic lung disease, bone marrow, BMI, your metabolic index, and then adjusting for age, race, insurance, current smoking, presence of comorbid conditions, giving of co-interventions such as tocilizumab, azithromycin, and then vital signs, laboratory tests on presentation and severity of illness. So all these confounders were controlled for in the analysis, and it showed that there is no significant association between hydroxychloroquine use and the endpoint of intubation or death, as shown here in this hazard ratio of 1.04 with a confidence interval of 0.82 to 1.32. So in conclusion, this large cohort of hospitalized patients with COVID-19 showed that hydroxychloroquine administration was not associated with either a greatly lowered or an increased risk of the composite endpoint of intubation or death. However, the study results should not be taken to rule out either benefit or harm, given the observational design and the 95% confidence interval, which is still relatively wide. So we cannot still rule out the possibility of benefit or harm. But at this point, the results do not support the use of hydroxychloroquine at present outside RCT. So this again highlights the need to still have a randomized controlled trial. So despite the large observational study, there are still unknown confounders that are not accounted for. And you have to consider that this large cohort was just conducted in one center in the US. So we still need randomized controlled trials. So what are the current recommendations? So the US NIH panel states that there are insufficient clinical data to recommend either for or against using chloroquine or HCQ for COVID-19. And if we are going to use it, we should monitor the patients for adverse effects, especially prolonged QTC interval. And several national guidelines also recommend the use of chloroquine for mild to moderate COVID-19 infections such as China, Italy, Belgium, and the US has, FDA has authorized the emergency use of this chloroquine as treatment for COVID-19. And similar to the Netherlands, now it also recommended off-label use of chloroquine for moderate to severe COVID. And in our country, our FDA also allowed us to use chloroquine and hydroxychloroquine for off-label use. And with that, PSMID came up with a guidance that we can use it among patients with probable or confirmed moderate to severe COVID-19 if there are no contraindications to therapy. However, as we review and see more and more studies on this, on hydroxychloroquine, especially with that large observational studies, we now have really to be cautious and offer chloroquine or hydroxychloroquine in a clinical trial setting as much as possible, unless there are contraindications to randomize the patient. So that will be included in the our update for the PSMID guidelines. So we have to take into account the new evidence that come up in the past weeks. Okay. And this just shows you the variability of the dosage regimens that is being used for chloroquine or hydroxychloroquine. Some would give a loading dose, especially for hydroxychloroquine, while other trials did not use a loading dose. And the reason for the loading dose is based also on pharmacokinetic studies. Then just to highlight here, they remind everyone on the adverse effects of chloroquine. So as mentioned, they have a similar toxicity profile, but HCQ is better tolerated with lower incidence of QTC. So these are the cardiac adverse effects: QTC prolongation, torsade, ventricular arrhythmia, and cardiac death. And it's higher with chloroquine. And then we have to be careful with the drug-drug interactions, which can increase the risk for QTC prolongation. So your antiarrhythmics, antipsychotics, antifungals, macrolides, including azithromycin and fluoroquinolone. Okay. So it's recommended to do baseline and follow-up ECG if you decide to give chloroquine to your patients, especially if there are potential drug-drug interactions or the patient has underlying cardiac disease. So the risk-benefit ratio should be closely assessed for patients with cardiac disease, history of arrhythmia, those with electrolyte imbalances. And these are other adverse effects to watch out for: hypoglycemia, rash, nausea, retinopathy, bone marrow suppression, particularly with long-term use, but not likely with short-term use. So that's for chloroquine and hydroxychloroquine. Now let's move to an antiretroviral, the lopinavir ritonavir. So replication of SARS-CoV-2 depends on cleavage of polyproteins into an RNA-dependent RNA polymerase and helicase. And the enzymes responsible for this cleavage are two proteases, the 3-chymotrypsin-like protease and papain-like protease. So lopirito is an inhibitor of the SARS-CoV-3 chymotrypsin-like protease. And although lopirito has shown in vitro activity against the SARS coronavirus, it has poor selectivity index, indicating that higher than tolerable levels of the drug might be required to achieve meaningful inhibition in vivo. And it is also excreted in the GI tract, thus coronavirus-infected enterocytes might be exposed to higher concentrations of the drug. So we all know that lopirito is a combination drug used for HIV. Lopinavir is the protease inhibitor, while ritonavir increases the concentration of lopinavir. And the rationale why it's being tried in SARS-CoV-2 is it has been shown that patients with SARS appear to reduce viral load and when given lopirito, and it was also recommended for MERS-CoV. So what data do we have clinically? So there are case reports that have shown that lopirito may be beneficial in patients with COVID-19, and it has been shown into observational studies that it may decrease the duration of viral shedding. However, the RCTs did not significantly show clinical improvement, did not reduce mortality or decrease viral RNA detectability in patients with COVID-19. So in particular, the RCT by cow published in New England Journal did not show this, and a modified intention to treat analysis showed some reduction in the hospital stay. But again, since this is a small RCT, the results are still inconclusive. And most common adverse events were nausea, vomiting, headache, increased cholesterol, and triglyceride levels. And currently, there are at least 16 ongoing trials on lopinavir, ritonavir, including the WHO Solidarity Trial. So what are the current recommendations? The US NIH panel recommends against the use of lopirito or other HIV protease inhibitors for treatment, except in the context of a clinical trial, based on the pharmacodynamics of the HIV protease inhibitors. WHO also does not recommend this, and China suggests the use of lopirito in COVID-19. There are also trials that are looking at the combining lopirito with an immunomodulator such as interferon gamma, interferon beta. So for PISMI, there is insufficient evidence to support the use of routine lopirito for COVID-19 infection based on the RCTs that I cited earlier, with inconclusive evidence on clinical improvement, 28-day mortality, and viral shedding. Now let's look at other broad-spectrum antivirals, the remdesivir and favipiravir. So remdesivir is an intravenous investigational nucleotide prodrug of an adenosine analog. And again, in vitro, it has been shown to have activity against SARS-CoV-2 and against SARS coronavirus and MERS-CoV. And this drug was also used during the Ebola epidemic as a study, as part of a clinical trial. So remdesivir binds to the viral RNA-dependent RNA polymerase, inhibiting viral replication through premature termination of RNA transcription. So clinical data shows us that, again, there is a small RCT conducted on patients in China. It showed no benefit in clinical improvement. Then there's also a case series that was published in the New England Journal in 61 patients from 9 countries, which showed some improvements. But again, because this lacks a control group, this benefits needs to be confirmed in large RCTs. So there are 13 clinical trials ongoing, including 7 ongoing RCTs and 2 suspended RCTs. So based on this, the current evidence show no clear benefit in terms of clinical improvement and mortality. However, there is emerging evidence from 2 large RCTs conducted by the US NIH. You've probably heard this in the past week, in the press release, that this adaptive COVID-19 treatment trial, which compared remdesivir with placebo, and another large RCT comparing 5-day versus 10-day course of remdesivir, showing clinical benefits. Okay. Specifically, they say that preliminary results indicate that patients who receive remdesivir had 31% faster time to recovery than those who received placebo. And it also suggested a survival benefit with a mortality rate of 8% among those receiving remdesivir versus 11.6% for the placebo group. So these preliminary results prompted the FDA to issue an emergency use authorization for remdesivir among pediatric and adult patients with severe COVID-19 disease. So we eagerly await the publication of these 2 large RCTs to be able to really say whether is it really the wonder drug that we are waiting for, or is it just a helpful drug that can be used in combination with other antiviral agents or with immunomodulators. So we still need to be cautious, with our optimism with regards to this with regards to the press release on potential clinical benefits, because we really need to see the full results. And as of this time, it still needs around 4 to 6 weeks for the follow-up of the patients to be completed to be able to come up with the full publication. Okay. So this is just the dose of remdesivir. Now let's move to favipiravir. So this is another broad-spectrum antiviral, probably the least studied among the antivirals. It's a prodrug of the purine nucleotide favipiravir ribofuranosyl triphosphate. It inhibits also the RNA polymerase, halting viral replication, and preclinical data is derived from its influenza and Ebola activity and broad activity against RNA viruses. There are currently 9 ongoing clinical trials on favipiravir, 6 in China, 2 in Japan, 1 in Thailand. And early studies showed that 2 RCTs did not show. So the first RCT on favipiravir versus umifenobir or Arbidol did not show significant difference in clinical recovery for patients with moderate to severe COVID-19 infections. And another open label trial, on the other hand, showed some significance in reducing viral clearance and higher chest CT scan improvements compared to lopirito in patients with non-severe COVID-19. These studies, however, have serious methodologic issues and results should be interpreted with caution. Hence, there is now also a large multi-country trial on favipiravir compared to standard of care. And the Philippines is participating in this as well, with Dr. Nina Berba as the lead investigator for the Philippines on favipiravir versus standard of care. Okay. Then just a few words on convalescent plasma therapy, which is currently being given as for compassionate use in St. Luke's and in PGH. So what is the evidence behind convalescent plasma therapy for critically ill patients with COVID-19? Okay. So first, the rationale behind this. So passive antibody therapy. So this is in lieu of not having any vaccine at this time. This passive antibody therapy is being offered through administration of antibodies against a specific antigen. So from patients who have recovered from COVID-19, their antibodies are the ones extracted and being given to the patients. And this is based on studies done on SARS, MERS, H flu, and Ebola, which is based on the rationale that it's supposed to provide immediate immunity to susceptible individuals by infusing passive antibodies. However, there are only a small case series and cohorts available at this time to showing potential clinical improvement with the use of convalescent plasma, but no studies on long-term safety profile. So this provides the rationale for really conducting good clinical trials. No? So there are currently 5 ongoing trials on the use of convalescent plasma, and there is at this time insufficient evidence to support the routine use of convalescent plasma for critically ill patients with COVID-19 unless it's in the context of a clinical trial. So for information of everyone, if you would like to be updated on the evidence behind all the drugs that are being investigated as either as adjunctive, antivirals, or immunomodulators, then evidence for diagnosis, for infection control, you can go to our website in InPSpeed, which houses the compilation of rapid evidence reviews on COVID-19 management. This is initiative done by our graduates and students in clinical epidemiology. through the leadership of Dr. Inday Dance and Ian Cabaluna. So from the Institute of Clinical Epidemiology and Asia Pacific Center for Evidence-Based Healthcare. Okay, so we've discussed the drugs that we use for mild, moderate, and severe COVID patients, and this is the algorithm which summarizes how we manage these patients with probable or confirmed COVID-19. So based on their respiratory status and whether they have comorbid conditions or are they elderly, then we classify them as mild, moderate, or severe. So for mild, they can be sent home, observed at, or isolated in quarantine facilities, our isolation facilities, and given supportive care. And those who are elderly with unstable or stable comorbid conditions presenting with pneumonia are the ones that we admit. So what are the challenges that we have as of this time as we move towards controlling the pandemic? So surveillance and contact tracing is still a challenge that we have to continue. We have to continue to have heightened surveillance and contact tracing if we are to control the pandemic. So for those in the emergency room, the clinicians, it is very important that you document the epidemiologic history, the source of exposure, the address of the patient, because these are data that is needed by our epidemiology bureau, who are monitoring the trends of our cases. And it is also very important for contact tracing to be able to determine clusters of cases. Not just, we can have clustering in the hospital, clustering in the community. So these are very important data that we have to really take time in documenting the history of exposure. Of course, the screening and diagnosis is still a challenge at this time, so we still do not have a good test for screening the pre-symptomatic phase, which is why preventive measures is still have to be in place. Preventive and personal protective measures need to be in place. Administrative engineering controls have to be in place. Likewise, we do not have validated antibody tests at this time. We also do not know if we will develop prolonged immunity and whether the immunity that we will have is a neutralizing one, or what kind of immunity are we going to get? Or if you just get a mild disease, will you get enough immunity? So those are things that still we do not know. And then as for treatment, we also do not have yet at this time effective antiviral agents or effective therapies. Whether monotherapy or combination therapy will work and what is the timing of administration of these drugs are still up for researchers to answer. And for prevention, so it is ideally for antivirals, we want a vaccine, an effective vaccine. And there is a lot of research also going on for to develop vaccines against COVID-19. So there are at least now 8 phase 1 and 2 clinical trials, and there is also a solidarity trial for vaccines, calling countries who are interested to participate eventually in the phase 3 clinical trials of the vaccines. Of course, there are also prophylaxis is a question. Do we have effective prophylactic agents for our healthcare workers or for those who get exposed to COVID-19? Will chloroquine or hydroxychloroquine be an effective prophylactic agent also, similar to how it is an effective prophylactic agent for malaria? So as of now, as I mentioned, there are no medical therapies that have been shown to improve outcomes in patients with COVID-19. And the drugs that have demonstrated in vitro activity against SARS-CoV-2 virus or potential clinical benefits in observational or small non-randomized studies and small RCTs. So this has been the basis initially why we applied for off-label use, compassionate use, because of this in vitro results of small cases, small RCTs. Okay. But of course, we all know the limitation of observational studies and small RCTs. So there is still, as shown in the review of evidence, there are inconclusive results from these small RCTs, whether they are beneficial or not in treating COVID-19. So again, we need adequately powered RCTs, and they are now currently enrolling to establish efficacy of these proposed therapies. So we have the WHO Solidarity Trial, the ACT trial on hydroxychloroquine plus azithromycin, and then the USNIH anti-COVID treatment trial comparing remdesivir with placebo. So this is a real-time dashboard of the clinical trials for COVID-19, just to show to you how much activity there is in research. So this is an evidence network of the clinical trials of the top 15 interventions that are being tried now. So you have your antivirals here, antimalarial, antibiotic, immunomodulators, and you even have your traditional Chinese medicine here. So these are the trials that are being compared against standard of care. And then this curved arrow here shows to you the observational studies, the non-comparative trials that are currently ongoing. So to date, there are more than 500 clinical trials registered in various clinical trial registries, looking at these different interventions. And chloroquine is the topmost studied drug. So for those who are fans of network meta-analysis, this is how your network meta-analysis will look like after all these trials come out, if we are going to systematically review the results of these trials. Okay. What are the limitations of repurposed drugs? The use of repurposed medications relies on the assumption that the benefits, which we have been seen in vitro and in small case series or cohorts, will outweigh the associated risk. And these repurposed drugs have the propensity to cause acute toxicity, which may outweigh the undefined benefit of a specific antiviral agent. The toxicity also can be augmented with combination therapy and in the presence of comorbid conditions. So therefore, when we offer this to our patients, we need to assess closely the risk-benefit ratio. And overall, the paucity of evidence demonstrating clear benefit may not justify the risk of the repurposed agents, especially for patients at high risk for toxicity and in situations where adverse events may preclude entry into investigational trials. So, should you give supportive care or an investigational drug to your patient? The priority is to enroll a patient in a clinical trial if they qualify. If it is not possible, then patients who are stable and can be managed as an outpatient, do not have any evidence of hypoxemia or pneumonia by imaging, then you can manage them with supportive care alone. However, patients with evidence of hypoxia or pneumonia, especially those with risk factors for disease progression, such as the elderly, those with comorbid conditions, immunosuppression, they may be considered for specific COVID-19 therapy after discussing the risks and benefits with the patient and in accordance with our local guidance. No? So if it's approved by FDA for compassionate use, however, it's very important to get informed consent. So is it ethical to use off-label drugs? It can be ethically appropriate to offer individual patients experimental interventions on an emergency basis outside clinical trials, provided no proven effective treatment exists. It is not possible to initiate clinical studies immediately. The patient or legal representative has given informed consent, and the emergency use of the intervention is monitored. So the outcomes needs to be monitored, and the results should be documented and shared in a timely manner with the wider medical and scientific community. So these are the conditions also that is being implemented by our FDA, and what we have to follow when they allowed us to use the off-label drug or repurposed drugs for COVID-19. So the decision to offer a patient an unproven or experimental treatment is between the doctor and the patient, and it must comply with national law. So again, wherever possible and feasible for the treatment to be given as part of clinical trial, we should do this unless the patient declines to participate. And if it's not possible to give it as part of the clinical trial, then we have to monitor the outcomes as mentioned. If early results from an unproven or experimental treatment are promising, then the treatment should be studied in the context of a formal clinical trial. So we cannot continue to be using these drugs on an off-label, repurposed, compassionate use. We have to move to a formal clinical trial to establish safety, efficacy, risk, and benefits. Now, do we have clinical trials? Yes. Fortunately, we are now part of the WHO Solidarity Trial, which I'll discuss in the next slides. And I mentioned that we will also have the hydroxychloroquine plus azithromycin trial, the favipiravir. And then for diagnostic test, we have the Covenant-1 trial, which will validate and evaluate the rapid antibody test. And then we have initiated some small trials on tocilizumab and in PGH, and PRA is also looking at summarizing or reviewing the outcomes of patients who are given tocilizumab. Then we have to look at the clinical profile, risk factors for mortality, risk factors for progression of our patients who develop COVID-19. And there is also a clinical trial now that has been formulated to determine the efficacy of chloroquine or hydroxychloroquine as prophylaxis for healthcare workers. Okay. So just a few words on the Solidarity trial. So this is a public health emergency trial initiated by WHO to look at the effectiveness of antiviral agents against local standard of care. So it aims to look at the effects of antiviral treatments on in-hospital mortality as the primary outcome, and the secondary outcomes are duration of hospital stay, use of ventilation, or intensive care. So what are the drugs that are being studied in this Solidarity trial? So patients who fulfill the inclusion criteria of probable or confirmed COVID-19 hospitalized patients will be randomly allocated to these 5 arms: standard of care, remdesivir, lopinavir, ritonavir, lopirito plus interferon, and chloroquine or hydroxychloroquine. For our country though, we still do not have interferon, so we are only randomizing the patients into 4 arms: standard of care, remdesivir, lopirito, and chloroquine or hydroxychloroquine. Okay. And these are the data that are being collected. So randomization is done centrally and data is recorded electronically. it uses a randomized adaptive design, meaning extra arms or additional treatment arms may be added while the trial is in progress, depending on the review of the therapeutics committee on evidence that comes out on these various antivirals. Okay. And then interim analysis is monitored by an independent global data and safety monitoring committee. So depending on what the data and safety monitoring committee is seeing as the patients are being enrolled and as outcomes are being recorded, so extra arms may be added or an existing arm might be stopped. So depending on whether benefits or harms are being seen as more and more patients are enrolled. So that's the adaptive design. And since it's adaptive, there is no specific sample size. The larger the numbers entered, the more accurate the results will be. Of course, the numbers entered will depend on how large the epidemic becomes. So it's anticipated that several thousands of patients will be recruited into the trial. And since it's also a large trial, there is an opportunity to do a subgroup analysis by country, by severity of illness, by age group. So heterogeneity between populations can be addressed through subgroup analysis. So again, the primary outcome is all-cause in-hospital mortality. Secondary outcomes, duration of hospitalization and use of ventilation or intensive care. So the Global Data Monitoring and Safety Committee will be the one to independently evaluate the analysis and inform WHO if the results are robust for general release and for affecting global recommendations. To date, recruitment for this trial started March 22, and there are now 224 participating hospitals in 14 countries. Okay. And as of May 8, 2,285 have been enrolled. These are the countries that are currently enrolling. So you see that a major part of the enrollees are from Iran, France, Spain, Norway, and for Philippines, we have contributed for Philippines, there are 24 site hospitals participating. So these are the 9 government hospitals. The ones in bold are the ones actively recruiting already. We have 15 private hospitals. Again, the ones in bold are actively recruiting. And so as of May 11, we have enrolled 81 patients from 12 hospitals. Okay. These are the number of patients enrolled per day. Okay. So just like to end this with saying that this is not a race against each other, but a race against time to find the effective treatment for COVID-19, to find also the effective vaccine for COVID-19. So it's not a race against institutions, against societies, against countries. This is the time where we really need to work together in solidarity to address the challenge of this pandemic. We need to be able to convince our patients to enroll in clinical trials, and we as clinicians should also be convinced that we have to enroll our patients in clinical trials so that together we can contribute to knowledge. We can determine which drugs are effective, which drugs are not working. And if they are not eligible for the clinical trial, then that is when we offer the compassionate use. But again, we need to get informed consent. We have to monitor and record outcomes. This is also probably the time that we need to work together to analyze the data that we have from all our patients. There is a lot that we can do if we will work together to share data and analyze, come up with systematic reviews for all the cohorts and for the treatment and preventive aspects of COVID-19. So I end this and thank you for your attention.
Thank you, Ma'am Isa. Thank you for that intensive lecture on the treatment and the ongoing treatment, the clinical trials, and the challenges brought about by this pandemic. We already have 500 participants in the Zoom meeting, and we also have gotten your questions already. However, because we still have another speaker, we'll entertain your questions after the second speaker. So our second speaker is an associate professor of the section of pulmonology, and she's also the section head of the section of pulmonology, Department of Medicine of the Philippine General Hospital. She's also the division head of the Division of Pulmonology of the Asian Hospital and Medical Center. She's also the consultant coordinator of the Comprehensive Ambulatory Respiratory Rehabilitation program and stop smoking program of the Philippine General Hospital, and a coordinator of the Office of the Continuing Education, UP Manila. She used to be the director of the Postgraduate Institute of Medicine, College of Medicine, UP Manila. Our second speaker will talk about the pulmonology side of treatment of COVID-19, Dr. Lenora Fernandez. Ma'am, Lenny.
Good morning. So I'll be talking about the pulmonary part of the objectives. So I'll be dealing with the more severe type, the severe acute respiratory illness, or the C and D classification of your patients. So all your patients who will be hospitalized, expect that 18% will become severe and 14% probably among them will develop ARDS and need to be in the ICU. Now, when that happens, we know that it would mean a bad prognosis for our patients. In China, they have at least already modified their data. 38% is their mortality now among all the patients that they see that are hospitalized. In Italy, so this is one of the bigger cohort, among the ICU admissions in Lombardy, one of the first centers to be hit in Italy, they had a 26% mortality, whereas in New York, among all the admitted patients in 12 New York hospitals, their mortality rate was 21%. But once your patient becomes intubated and be hooked to a mechanical ventilator, there is a staggering 88% mortality. In UK, they have a running cohort data, and it's the same. They have a 75% mortality once your patient becomes intubated. Survivors from the non-survivors among all those who were admitted and were COVID positive. So as you can see here, our mortality rate is around 18%. And looking at the risk factors here in our local data, age definitely is a risk factor. Having comorbidities would also be a very strong risk factor. And subsequently, during the course of the patient, if a secondary infection happens, if there's a need for mechanical ventilator, or an acute kidney injury happens, or a patient goes into ARDS or shock, that will also, of course, spell a possible mortality for your patient. We looked at the lab data that we had. We looked at the inflammatory markers, and it's the same. The thing that we see about the cytokine release storm, it is happening. Lymphopenia is an indication that your patient would have a poorer prognosis here. As we can see, it would speak really of a COVID infection. Your neutrophil to lymphocyte ratio is another predictor. D dimers, ferritin, CRP, and LDH. As we can see here, troponin was not an indicator of surviving or not surviving. So we go now, of course, to the model of the cytokine release storm. So this is our natural response when the SARS-CoV-2 would infect our body. There is tropism to the lung tissues somehow, especially to the vascular endothelium, and that will explain probably later why there is a different kind of ARDS in SARS-CoV-2. Nevertheless, what happens, and this is what we can't explain yet, is somehow our response sometimes is not enough. 80% of the population who are infected, as we know, by SARS-CoV-2 would end up being recovering or not even being symptomatic, probably in some cases. But somehow 20%, 18%, and then eventually around 5 to 6 or even higher would end up with dying from the disease. So why does this happen? We still really don't know why there's an imbalance. And we know that it would be the proliferation or the exacerbation of the cytokine release that becomes a storm, and that leads now to the destruction of the lung, of the tissues of the patient, mostly in the lungs, but of course it affects the other tissues as well. So we know that the CRS would happen usually at the latter part, but somehow it can happen as early as, of course, as the 3rd to 5th day. And when the imbalance happens, this will snowball now into affecting all the tissues, especially the lungs, leading to ARDS. So this diagram, I'm sure you've seen this in many lectures already, but this is just to emphasize that these are now the cytokines and the immune cells that are involved. So the IL-6 would be very prominent here because it is a pro-inflammatory cytokine here. And that's why one of our treatment, like the tocilizumab, is directed against IL-6. The other medications that Dr. Isa already explained earlier would of course hit either the virus or help in terms of decreasing the cytokine release storm along the way. Now, of course, the dilemma would be to find the sweet spot. And this is still the thing that we still don't know really. When is the proper time to situate now your immune modulators and to situate, of course, your antiviral agents? But usually everybody is of the same thinking right now that that sweet spot has to occur early, but not too early that you will dampen your natural immune response to the infection so that you can recover. So this thing about when to give it this is, again, as I mentioned, not yet really fully elucidated, and we're awaiting the results of the randomized controlled trials and that. So usually many among the immunologists, many among the rheumatologists and the crit care specialists would believe that probably at the first sign of respiratory deterioration, such as your patient now manifesting still with dyspnea, being tachypnic of 30 or more, or still being hypoxemic with a SAT of 93% or less, despite your oxygen supplementation, or your PF ratio of being less than 300, or if you see a progression of the lung infiltrates of 50% or more within 24 to 48 hours, that can be a marker that the cytokine release storm is really ongoing. So this would be one of the recommendations of the Society of Allergy and Immunology here in the Philippines. And when this thing happens, then you have to really now up all your immune modulators as much as possible. So this did not happen. The thinking about how to deal with the CRS, as we fondly call it, did not happen overnight. This has been an ongoing phenomenon, and the diagnostic criteria last year by this immunologist was as such, and this is what we are actually following right now. So if this is happening to your patient, try to now up your immune modulators. Dr. Aleta, one of the members of the Allergo-Immunology Society, provided this slide where here we are summarizing all the trials so far on the immune modulators. So Dr. Isa has already discussed the convalescent plasma here and of course your HCQ. The other immune modulators that are often used here locally would be steroids, IVIG, and of course your IL-6 inhibitors such as your tocilizumab, as I mentioned. Now look at the status of the trials. Everything are still very small and we are still awaiting RCTs on this. So again, it would fall under the bracket of compassionate use or investigational drugs, as Dr. Alejandria already mentioned. Our PISMID guidelines has this guide as to when we should administer, for example, your anti-IL-6, your tocilizumab. So again, if your patient is now deteriorating or you think that there is a full-blown CRS, then that would be the time that you can give your tocilizumab, for example. Now remember that this is an anti-inflammatory agent and there is the possibility of superimposed bacterial infections happening. Cochrane reviews and other systematic reviews on on RA before the COVID situation showed that there might be a signal regarding that, but it's not really sure yet. So if we give our immune modulators, we also have to be cautious against the possible superimposed bacterial infections happening in this kind of a scenario. So we asked the Chinese doctors who came over, how many immune modulators can you have at the same time? And their expert advised that probably around 3 only max should be present, because again, you would run the risk now of tipping the balance into immune suppression, overt immune suppression for your patient that it has nothing to defend with already against the other infections. For systemic steroids, these would be the trials. And again, they're quite small and they're not really definitive yet. So that the latest guidelines probably would be the US NIH, and they have these recommendations here. So again, to reiterate what Dr. Alejandria mentioned, there is no antiviral yet nor immune modulatory therapy that has really been proven against COVID. And the use now of empiric broad spectrum antimicrobial therapy has to be quite prudent and balanced, because if you're quite sure that this is really a COVID infection and there's no need for a bacteria antibiotic coverage, then you might opt not to do so. And again, the use of systemic steroids is not really indicated, except probably for some specific situations here, such as refractory shock. Our unified guidelines has the same statement here. Do not routinely give systemic steroids for treating viral pneumonia or ARDS outside of clinical trials unless they are indicated. Now, I'd like to show this other drug, which is quite a controversy, especially among probably the cardiologists, your ACE inhibitors and your ARBs, because your SARS-CoV-2 would attach, of course, to your angiotensin receptor in our cells. And this is the latest study that was published in JAMA. This is still just a retrospective cohort, and they were able to show here that the use, of course, of your ACE and your ARBs is not associated of getting really the COVID infection or having a worse outcome from the COVID infection. So go ahead and just continue those medications. The other immune-based therapy that we mentioned, the IVIG, the convalescent plasma, again, the guidelines would all still say that there is insufficient clinical data. Even for tocilizumab, we have insufficient data for that. There are other drugs that are being studied. There's a trial which already was published about anakinra, and the sarilumab also, they have an ongoing trial on this anti-IL-6. So this would be the guideline that PISMID brought out. Quite, of course, really tracing. It's just an investigation. Now, many of our nephrologists, and there's a rationale behind it, because it will now, of course, help you extract or remove or clean the blood of the patient from the cytokine that is overly present in our patient. So this has been quite helpful, but there are really no trials that I saw online yet on hemoperfusion in decreasing CRS in COVID-19. I think the East Avenue group, because they didn't have tocilizumab for a long time, used hemoperfusion a lot, and they used it early on among their patients who were manifesting with hyperinflammation and ARDS. And it helped them a lot in terms of abating or even lessening the acute lung injury of their patients. So we're awaiting their cohort data if they're willing to share that. So this is a very common thing that is being done now in the critical care units among severely ill COVID-19 patients. So again, in our data in the private hospital where I practice, this is our data among those who were COVID positive, as I mentioned, comparing the survivors to the non-survivors. As you can see, we utilize a lot all of the interventions that we've mentioned. Of course, it is expected, because this is a retrospective cohort, that those who had a poorer prognosis had more interventions, and therefore many received more of these interventions compared to the survivors. So you can see that we used the HCQ and CQ a lot. Also, the lopirito was around a third of our patients received it. We had fortunately TOSI for a longer time compared to the other institutions. So around 22% of our patients were able to receive it. There was a time that we used steroids, no, because we really saw that there was an abasion or an amelioration of the inflammation, or an improvement in the oxygenation among our ARDS patients. So there was a group of patients where we gave it around 3 to 5 days and just at 1 mkd of the methylpred. So we also used hemoperfusion, and of course, anticoagulation as part of VTE prophylaxis was done. We were able to give a convalescent plasma to 2 of our patients, and also IVIG treatment. Now, going now to our patients who would really suffer acute lung injury and go into a full-blown ARDS. This is the X-ray of my patient who was in ARDS. And it would be the same ARDS picture that we see among non-COVID patients. There would be the diffuse alveolar damage here. But what's quite prominent among the autopsy findings of our patients with ARDS from COVID is that there are a lot of microvascular thromboemboli that are present, or thrombi that are present. And there's also a lot of capillary overcongestion here. So this changes a little bit how the COVID ARDS is, so that we have a term now, CARDS, and this would refer to COVID ARDS due to COVID. So of course, many of you have heard about this already, where the famous pulmonary physiologist, Dr. Gattinoni, has this theory that there might be at least 2 distinct types of our ARDS patients suffering from COVID. Because what we noted is that there are some patients who would be very hypoxemic, but when we check the lung compliance of the patient, it's not quite high. It's quite still good, but the patient is relatively hypoxemic. So we term these patients as the L phenotype, whereas the usual full-blown ARDS patients that we see is what we call the H phenotype. So the L phenotype is a low elastance, low lung weight type of CARDS. And we assume that this is just really an early state of the CARDS of the patient, and eventually some will evolve to the more severe type, which is the H phenotype, which has a high elastance or a very low lung compliance and a high lung weight. So you can see here that we can differentiate between the two by X-ray or by CT scan, where the lungs are more flooded here. Now, the thinking is, why is your patient very hypoxemic even when their lungs still don't look that bad in terms of their ARDS? The theory is the inflammatory markers that are present a lot or in excess in the patient would somehow cause vasodilation at those areas where your blood vessels are supposed to constrict, where these are not aerated anymore. So those alveoli that are full now of your lung edema, there should be a concomitant vasoconstriction there, so that there will be a VQ match, that would be the natural compensation of the body. But because of the hyperinflammation, there's a lot of vasoplegia, there's a lot of vasodilation still happening, so that there's a lot of VQ mismatch, and that this now would heighten the hypoxemia. So this is not just pure academic, a pure academic discussion, but rather it has an impact on how now we would ventilate our patients. So those patients who are in the L phenotype, where the lungs don't look that bad yet, but yet they're hypoxemic, what we do is try to avoid invasive mechanical ventilation and try to opt still for non-invasive ventilation. But if your patient, you see, does a lot of work of breathing on non-invasive ventilation, you now have to still move your patient to be intubated and hooked to a mechanical ventilator. But you try not to give too high a PEEP, and you try to make your tidal volumes a little bit bigger to accommodate the still good compliance of the lungs. So here, the L phenotype, as you can see, these are now the treatment recommendations here. The name of the game is still to protect the lungs from further injury. Our premise is, once you intubate a patient and hook him or her to a mechanical ventilator, there always will be a lung injury happening. So the more we try to avoid it, the better. But if the work of breathing will be too much for the patient, there will be a lot of shearing inside the lungs that somehow you still have to go ahead and proceed to intubate and ventilate the patient. So our society, the Philippine College of Chest Physicians, came up with these guidelines very early on in March in terms of how we will manage our patients suffering from ARDS, so, or from severe acute lung injury. So of course, if your patient is hemodynamically unstable or there's imminent arrest, then of course you go ahead and intubate your patient with the usual indications that we have for intubation. But if you see that your patient is hypoxemic, yes, and they would respond to just oxygen supplementation, good. Try to avoid an immediate intubation and mechanical ventilation. Now, before we had this note that we should not use non-invasive ventilation. This would be our BiPAP, our CPAP machines, or our high-flow nasal cannula. This was the thinking that we might be causing more aerosol dispersion when we do such maneuvers. However, many now worldwide, and almost all societies worldwide, would still advocate using non-invasive ventilation as your first option for your patients who remain hypoxemic despite giving your oxygen through nasal cannula or face mask. However, here is now one of the studies or articles that were put out in terms of how much are we really dispersing the COVID viral particles by our respiratory maneuvers. So here, nebulizer does disperse your COVID particles a lot. So do not nebulize your COVID suspects or your COVID probables. And here we can see that using the non-invasive ventilation in the form of your CPAP or your BiPAP disperses a lot of your aerosol. Using your simple oxygen mask or Venturi mask is quite safer, and using your nasal cannula. Now, the nice thing to do if you need to do your NIV would be using the helmet type of NIV, but this is not available in the Philippines right now. This is the non-rebreather mask using for your oxygen, and this has quite a good control of dispersion of aerosols. And the one that is now the favorite throughout the world will be the use of the high-flow oxygen nasal cannula. As you can see, even if there would be a high flow of your oxygen and a little bit of a higher pressure compared to usual oxygen supplementation, aerosol dispersion, as you can see, is not that much. So it's quite safe as long as you give low pressures with your high-flow nasal cannula. So now, to revise our guidelines, we opt to now put the option of using your high-flow oxygen nasal cannula as a stopgap measure, hopefully to avoid intubation, but not to delay intubation, of course, if it's needed. Now, you do this if your patient is awake and cooperative, he's hemodynamically stable, and your PF ratio is low, or he's still hypoxemic despite your oxygen supplementation. And make sure that he is not hypercarbic, because if he is, then that means a very poor work of breathing. You need to go ahead and probably intubate the patient if you cannot do the helmet type of NIV. And we put here now, consider self-proning. So we put this number here. We'll talk about it a little bit later. As to this number, this parameter will help us decide if your patient is doing well on this high flow oxygen nasal cannula or if you need to intubate. So this is how it looks now, the machine here. We put a surgical face mask over the patient so that it would, of course, lessen further dispersion of the COVID particles. So if you're going to use this, use only the max pressure flow of 30 liters per minute and not beyond. This is the principle of how your high flow oxygen nasal cannula would work. There's a higher flow, there's an oxygen blender aside from a higher pressure flow generated by the machine. This is very much less expensive compared to your ventilator. This is around 350,000 pesos. Now, what would be the advantage here in terms of the work of breathing of the patient? It obliterates the oropharyngeal dead space in the patient. So again, it helps in the work of breathing of your patient and helps recruit, improves the FRC or functional residual capacity of your patient. When do we consider high flow nasal cannula? As I mentioned, patient should be awake and cooperative, hemodynamically stable, still hypoxemic despite your oxygen supplementation, and not hypercarbic. So if he is hypercarbic, go ahead probably and intubate and do invasive mechanical ventilation. How to monitor the response of the patient? We call it the ROX index, which is just plainly your SpO2 over FiO2 over the respiratory rate of the patient. So from the study of Dr. Roca, who is the father of this ROX index, if your computation is above 4.88, then it predicts a good response to your non-invasive ventilation. And if it's less than 2.5 at 2 hours time, then that predicts that the patient might fail and go ahead and probably intubate the patient. Or if at the 6th hour, your index is less than 3.47. So this was how the study was conducted here. Now there's only 1 or 2 trials here, and this is one small trial in China on high flow nasal cannula in COVID SARI. And take note that if the PF ratio was less than or equal to 200 for your patient, there's a likelihood of failure of 29% eventually becoming still intubated after starting off with high flow nasal cannula. The next intervention we'll talk about is self-proning. So self-proning would be just asking the patient to lie down on his chest or lie on the side. So what is the principle behind it? It's now to again try, we call it a shape matching, where when you lie down, most of the lung edema fluid will be at the dorsal area. So when you now do your prone, there would be a shifting of that fluid, and somehow this causes a sustained improvement in your ventilation perfusion match. So there is reduction of the shunt and improvement again in the work of breathing and recruitment of your alveoli here. So this is the pamphlet that is used in the UK. Our own Philippine Society of Critical Care Medicine has their own pamphlet now, so we're trying to get hold of that. This is how you will do self-proning, which you can start even at the ER, and probably even for your patients who are whom you send home after a pneumonia, they can do this. So 30 minutes of lying, 30 minutes to 2 hours of lying prone there, and then lying on the side after, to the right and then to the left, and the patient can sit up in between. So of course, when the patient has just eaten, have a 2 hours gap of sitting down before, of course, they go prone again. So they can now alternate these positions here. So far, only 2 case reports have been done on self-proning. So this is just one case report, and this one is a little bit bigger. The one done in New York, they were able to see in the ER that there was an immediate improvement in the oxygenation of patients who were self-prone in the ED. And we're again waiting the RCTs here. So for example, your patient, you put him on high flow nasal cannula, or you decided to intubate immediately your patient. how now should you do your invasive mechanical ventilation? So remember, when you intubate, complete PPE should be worn, and you have to try to do it as quickly as possible and minimize aerosol dispersion. So an RSI is recommended. If you have a video laryngoscope, use that. Try to avoid bag valve mask ventilation. If you really have to do so, put a HEPA filter on your bag valve mask and put a mask probably over the mouth of the patient, or some would even use the acrylic box, no? And then sedate and paralyze the patient to minimize coughing also. And now we, of course, now use the lung protective strategy that is popular with the ARDS net when we now put our patients on mechanical ventilation. We usually would advocate 4 to 6 ml per kilogram of the tidal volume. But with the thinking of the L phenotype, if you believe your patient is in that category, you can opt now for a higher tidal volume of 8 ml per kilogram of predicted body weight. In terms of PEEP, we were so gung-ho before with our usual ARDS, but now again, with the consideration of the L phenotype, we try to go lower in terms of our PEEP. Usually we try not to exceed above 14 if needed. And the very important thing is to keep your lungs dry, no? Because to improve, of course, your ventilation perfusion match, we give our vasopressors when needed. Before, we had this recommendation of giving vitamin C and B and zinc. We're still awaiting, RCTs on this. There's an RCT on vitamin C, I think, which did not really prove it in COVID. And again, no steroid use unless with refractory septic shock. No nebulizations, as we mentioned, instead use inhalers. So you can have an MDI adapter hooked to your ventilator limb, so you can use your MDIs rather than nebulize your ventilated patients. And make sure that you do closed system suctioning. So now we go to prone positioning again. Our intubated patients, if they remain hypoxemic, then we do put them on prone. So here would be a demonstration how patients are prone again. And there is only one small study on this, which showed an improvement in oxygenation, but no improvement in compliance. So look here at the effect of proning. At the end of proning, we see an improvement there. Some patients might be offered ECMO. It's very expensive here in the Philippines, but it is available in the Philippines for those who really are have refractory hypoxemia. So this is the statement of the ECMO group in the Philippines. We have one ECMO going on in my hospital, but that patient is a non-COVID right now. So if you're dealing with these very critically ill patients, what are we in for? In Italy, we can see that 88% in their ICU were intubated and put on invasive mechanical ventilation. 27% were on prone. And in Seattle, they had this cohort of 24 patients here. More were on high flow oxygen nasal cannula, as you can see here. And still a lot were on invasive mechanical ventilation. Again, proning was done in 28%, and they had no ECMO patient in the Seattle cohort. This is our experience in my local private hospital here. So 88% among our patients were intubated. We do sedation and paralysis among our intubated patients. We did proning in 31%. We did a lot of hemoperfusion among our patients, and 33% were able to receive TOSI among our critically ill patients, and 2 were able to receive convalescent plasma as well. So the last topic would be VTE. So this is a hot thing again. And the Netherlands study would show that indeed, despite VTE prophylaxis, 20% of patients who were COVID positive still had VTE, and 13% were symptomatic. Many among them were in the ICU. So the ISTH has this guideline, and most of the institutions right now would use the D-dimer that if it's 6 times the upper limit of normal, then you go ahead and give the full VTE dose, even if your patient does not fulfill the Wells criteria, for example. So this is a summary of all the discussion we've had for ARDS and severe acute lung injury from COVID. This is the famous table of Marini and Gattinoni. Now, lastly, of course, we have to consider the ethical part because we're dealing with very sick people who have a 75% mortality rate. So, of course, advanced directives have to be discussed. It's difficult with all the infection control measures. We are not able to talk face to face with the relatives of the patients, for example. And we welcome you to explore also our ethics guideline here. We have our some sample informed consent and advanced directive forms in this document here. So the issues and challenges for our seriously ill patients or who are in the ICU from COVID, we're still in clinical equipoise, as Marisa or Dr. Alejandria pointed out. Finding the sweet spot is still not possible right now. It's a very expensive and exhaustive thing for our patients and for us also, the healthcare workers, when we deal with our ventilated patients, and we still yet have to demonstrate an objective improvement in mortality. But we have to be optimistic. Good things happen from this thing. Heroism, we saw it. People really became frontliners. Teamwork was seen. The specialty differences were obliterated. Everybody was working together, and we saw obstetricians and even surgeons doing frontline work. Equipment was given to the needy hospitals, and fortunately, we are not yet actually in a crisis situation right now that we did not need to allocate ventilators to our patients. We were able to prepare for it and stockpile, and innovativeness happened and facilitation of research as well. So our PGH group was able to innovate with this venti mask, and we're doing some phase 1 and phase 2 trials on this right now. So there are a lot of challenges ahead. Finding the sweet spot in the cytokine release storm, or even preventing the cytokine storm from happening, preparing for the second surge where we will always be protected. Antimicrobial stewardship has to be performed. And how do we now handle our patients who have recovered? How do we now handle their sequelae? And of course, we're neglecting somehow our non-COVID patients. We have to take this into consideration, and the training of our residents and fellows. And how do we now proceed with our COVID research that we've seen actually the cases dwindling right now? So I have the same recommendations as Dr. Alejandria, that there has to be a multi-center collaboration and networking. The DOH has at least helped us do a good networking, having a tracker on the health system capacity, and we do have to prepare for the new norm and the second surge. Thank you.
Thank you, Ma'am. Thank you, Ma'am Lenny, for that extensive management in the pulmonary side of the treatment of COVID-19. We do have questions. We actually have a lot of questions, but due to the limited time, we'll just ask a few questions for both Dr. Alejandria and Dr. Fernandez. So, Ma'am just an FYI for Ma'am Isa and Ma'am Lenny, there are in the participants, there are non-medical doctors in the Zoom meeting. So may mga questions sila po for the benefit of our non-medical colleagues and attendees. Can you give us any updates on the development of vaccines for COVID-19, the challenges of developing a new vaccine, and how soon can we expect vaccines especially here in the Philippines? Ma'am Isaac, the updates on vaccines and the challenges of developing a new vaccines for COVID.
For vaccine development, there are actually 100 candidate vaccines that are in preclinical evaluation. Okay, and there is one repurposed vaccine, BCG vaccine, for healthcare workers that's being tried in Australia, healthcare workers. And then there are 8 candidate vaccines which are now in phase 1 to 2. So the challenge, there are different types of vaccines that are being tried. The RNA vaccine, inactivated, live attenuated. 12 to 18 months is the timeline if everything goes well. And WHO, as I mentioned, is setting up also a solidarity trial so that these candidate vaccines can be tried at a faster rate, rather than the usual timeline that we have. So hopefully in the last quarter, there will be a phase 3 vaccine that will be tried in humans. That's I think US, NIH, or Japan. If you read the papers, there's a lot going on in Japan, China, the US, Australia.
Thank you, ma'am. For Ma'am Lenny, from Luis Hora, how soon can one distinguish between the L and the H phenotype? And do you request a CAT scan once the patient becomes hypoxemic? I think this is more of a clinical question, Ma'am Lenny.
Yeah. So even just by X-ray, you can already probably see that if there's not much air or infiltrates going on, then you can immediately say that he would be in the L phenotype category. And if you did intubation and you're able to check the compliance of the patient and it's still quite good, then that will be another indication. We don't recommend CT scan left and right. First and foremost, you will be probably infecting also, no, the pathway going to the CT scan, and the CT scan has to be disinfected. So even abroad, they would just recommend CT scan for patients who are quite problematic. So we don't really need to do that. They only did it in China because they have a lot of CT scan machines there. In Netherlands, they did not even recommend that.
Okay, ma'am. To Dr. Alejandria, or even for Ma'am Lenny, are there guidelines to how many hours we should do a follow-up ECG? And how often do we need to repeat when we are using hydroxychloroquine?
So,
Isa, can you answer that?
Okay. We recommend doing a baseline ECG if you plan to use hydroxychloroquine. But first of all, you also need to assess first the risk of your patient for developing cardiotoxicity. So do they have history of cardiac disease? Are they taking drugs that can potentially interact with chloroquine that will increase the risk for toxicity? And then are there electrolyte imbalances? So this is I can share with you or email a risk scoring system that was developed by the cardiology section to guide us on which patients will be at high risk for prolonged QTC. So baseline is recommended, and then after giving the loading dose, we advise to repeat the ECG after day 1, and then every 3 days would be good enough to monitor for any prolonged QTC.
All right, ma'am. Thank you, Ma'am Isa. To Ma'am Lenny, are patients with tuberculosis considered patients with comorbidities? And are workers being treated for PTB allowed to go back to work?
Surprisingly, yeah, it's not considered as a comorbidity, but we consider it as a contraindication to giving some of the COVID-related medications. But that's a good thing. We'll take a look into that. And then we handle TB in the same way as our TB guidelines has espoused before.
All right. For Ma'am Isa, for building entry point temperature check, what is the ideal minimum temperature that we will refuse entry? DOH, DOLE, WHO, CDC have different claims. What are there temperature cutoffs based on literature and PCP recommendations? I think, ma'am, kasi di ba malilift na ang ECQ if malilift yung ECQ this May 16, I think a lot of questions really come from workers going back to work. Kaya may mga questions po tayo ng ganito.
Yeah. Yes, I've seen different cutoffs across all business and establishments. 37.8 is what is the consensus for now. And for me, more than just screening, doing this thermal scan, it's really the screening questionnaire that's more important, because you may not have fever at that point in time that you were scanned, but you probably having fever already within the past 2 weeks or so, than having any other symptoms. So the screening questionnaire is more important. A health declaration checklist is more important than really a temperature scan.
Okay. So it's more of the symptom checklist. To Ma'am Lenny, we talk about kanina thromboembolisms as a source of. So there's a question here. What treatment or palliative care can we do in case of COVID-19 patients at the same time HIV at the same time HIV kay Ma'am Isa pala to in VTE thromboembolism and with Factor 10A inhibitors are not allowed in the Philippines. What are the VTE COVID-19 thromboembolic drugs available? And is there any guidelines available for patients experiencing thromboembolism? I think it's a two-part question. What are the treatment management for patients who have thromboembolism? And what about, kay Ma'am Isa, what about patients with HIV and COVID-19 patients? Ma'am Lenny first, siguro po, how did you manage in the critical care with patients?
So we usually give the low molecular weight heparin. They're quite good, or even heparin. So we follow the usual VTE guidelines that we have.
Ma'am Isa, how about patients with HIV? And do you have patients with HIV and COVID-19 co-infection?
In my practice, I have not yet had any HIV patient with COVID-19. I'm not, but I'm sure other ID physicians probably have. So the same management guidelines follow. Of course, here we will not use lopinavir, ritonavir, because that's especially for HIV patients, we will not include that.
All right. Siguro po, second to the last question, Ma'am Isa, what's the dose of remdesivir that you give to patients?
200 milligrams at day 1, and then 100 milligrams IV for the next 9 days, once a day.
All right, thank you, ma'am. To Ma'am Lenny, siguro, usually those who are at high risk being mentioned are the elderly and those with comorbidities, especially with diabetes and hypertension. How is the prognosis for those with autoimmune diseases such as rheumatoid arthritis? Is it any better or just the same as those with diabetes?
Yeah, we did not see that group of patients in the different cohorts. Maybe here in the Philippines, we'll take a look at it. But theoretically speaking, of course, they would be immunosuppressed. A lot of patients with malignancies also have been seen to have a poorer prognosis.
Okay. All right, ma'am. So that will be, unfortunately, because of limited time. Let me just summarize the webinar for today. We talked about the treatment guidelines and medications presently available for COVID-19. What are the ongoing clinical trials and the future clinical trials that will be available here in the Philippines, particularly Solidarity. Ma'am Lenny also discussed the pulmo side of the management of COVID-19 and how to deal with ARDS. And of course, both of our speakers discussed challenges in the management in COVID-19. And of course, it has to be a multi-sectoral collaboration among stakeholders in this management of the pandemic. As what Ma'am Isa mentioned, this is not a race against each other, but a race against time to find effective treatment for COVID-19. So in behalf of the Department of Health and the Philippine College of Physicians, we want to thank everybody who are logged on to this webinar, both in the Zoom meeting and in Facebook Live. We would like to thank Dr. Isa Alejandria and Dr. Lenny Fernandez for those wonderful lectures that you've shared with us today. We invite you again on Wednesday for another series of webinar. Same time here at 10 o'clock a.m. So the next topic will be, are we ready to go to work? And this is a guidance for all workers. And it will be on May 13, 2020 at 10 a.m. So in behalf of the OH and Philippine College of Physicians, thank you very much for your participation. Thank you, Ma'am Lenny. Thank you, Ma'am Isa.
Thank you, everyone.
Thank you.
Thank you, everyone.
Thank you.
So marami pa yung sa Wednesday.
Alin?
Are we ready to go back to work?
Oo.
Kasi hindi lang doktor ang nanyan, lahat naman yun eh. Mga managers at mga empleyado. Ba't magtatanggap ka naman yan?
Si ano yan, Nina Verbang, inano ko dyan sa si Bella.